Hello, my name is Dr. Nina Kim from the University of Washington. I will be talking about a frequently encountered hepatitis B serologic profile, isolated core antibody. This occurs when someone is only positive for hepatitis B core antibody and negative for surface antigen and surface antibody. This profile tends to generate confusion and questions for many clinicians. By the end of this talk, you will gain better understanding of this profile. These are some of the key points I want to cover today. We'll walk through some virology and definitions, talk about the scenarios that lead to the serologic profile, and what the clinical implications may be, especially with respect to occult hepatitis B, Hep B reactivation, and immunization. Hepatitis B is a partially double-stranded DNA virus. The main marker of active infection is the Hep B surface antigen. This is a lipoprotein and a component of the envelope, and the major site for binding of neutralizing antibody. In addition to the surface antigen, the virus produces two nucleocapsid proteins, E antigen and core antigen. The hepatitis B E antigen is secreted into the circulation, while the Hep B core antigen is assembled to form the viral core, which is then later packaged as part of the intact virion. For this reason, we're able to measure E antigen directly in blood, but not core antigen. So this is a serologic pattern that evolves during acute infection that goes on to resolution. These three paralleling lines here are the main antibodies produced by the host after infection: core antibody, E antibody, and surface antibody. You can see here that the total core antibody in pink shows up relatively early in infection and persists at stable levels long past the initial infection. Clinicians have sometimes confused core antibody with core antigen. Remember, we cannot measure core antigen. We can only measure the antibody. So on its own, it does not necessarily indicate active infection. It simply reflects the fact that the individual has seen the actual virus at some point in their lives. So an immunized individual or an individual who has never been exposed to natural infection would not have core antibody. The other point of distinction I want to make is that core antibody should not be confused with surface antibody. In contrast to surface antibody, core antibody does not necessarily indicate immune protection, just prior exposure to the virus. An individual with isolated core antibody, by definition, has positive core antibody in the absence of surface antigen or surface antibody, the other seromarkers. It is a common profile, seen in up to 20 to 45% of persons with HIV and up to 31% in persons without. Factors associated with this profile include hepatitis C infection, injection drug use, multiple sex partners, older age, and if you have HIV, CD4 count less than 100, or HIV viremia. This isolated core profile is seen in one of four scenarios. The window phase of acute infection is a period of time when the surface antigen has basically gotten to below detectable levels, and the surface antibody has not yet quite developed, and it is in this seronegative window where you can sometimes just get an isolated core antibody. Keep in mind that you will not encounter this very often, and this individual likely has other clinically apparent manifestations of acute hepatitis B, including elevated liver aminotransferases. They will also likely have positive core IgM antibody. The second scenario is when you have someone who has seen hepatitis B and they have gone on to resolve their infection, but they basically had waning of their surface antibody to a level that is less than 10 or 12 international units per liter, which, depending on the assay, is the threshold we consider protective. The third scenario is chronic infection that can manifest as an isolated core antibody when the surface antigen has waned over time due to low production. We can sometimes see this in a chronic carrier state when they have started to gain some better immune control and therefore lose their surface antigen, or they have developed mutations to the surface antigen protein that have escaped detection by our standard assays. And finally, the fourth scenario is a false positive. One of the misconceptions out there is that most individuals with this isolated core antibody profile fall into this category, when in fact a false positive is rare. We did encounter these with older assays, but current assays for hepatitis B core antibody have very high, greater than 99% specificity. But you want to consider the possibility of this false result if you have a patient with no risk factors for hepatitis B, for example, one who is not from an Hep B endemic region such as Asia, Africa, or the Pacific Islands. What we have learned about this profile is that it is generally a stable pattern over time in most individuals. In one large cohort of individuals with and without HIV, this profile continued to be present in the vast majority of individuals when retested. If there was a change, the surface antibody would show up, and it was rare to see a transition to chronic hepatitis B profile, where the surface antigen was positive along with the core antibody. We have also learned that this profile does not appear to be associated with liver aminotransferase elevations or other evidence of active liver disease, at least in US-based settings. But what about the small subset with occult hepatitis B infection? So these individuals would have an isolated core antibody, negative surface antigen, but have detectable HBV DNA levels in the blood. The prevalence of this varies depending on the study you look at and can range anywhere from about 2% to as high as 41%. And this difference largely has to do with geography, the population studied, and the assays used. The true prevalence may be underestimated due to the cross-sectional nature of many studies and the fact that patients may be on HB-active antivirals. This is particularly the case if you're looking at HIV cohorts, but also quite variable. The bottom line is that the clinical significance and true extent of occult hepatitis B is not clear based on the literature, but the answer to the question, how worried should I be for occult hep B in isolated core patients, is generally going to be, don't worry, at least in US-based cohorts. How aggressively we hunt for this will depend a great deal on two things. One, where the patient is from, and two, what is at stake clinically. I tend to be more aggressive about hunting or watching for occult hepatitis B when the clinical stakes are high. One of these high-stakes situations is severe hepatitis B reactivation in the setting of hepatitis C treatment, which we did not see in the interferon era, possibly because interferon also has activity against hepatitis B. In October 2016, the U.S. Food and Drug Administration issued a drug safety boxed warning after identifying 29 cases of HBV reactivation in hepatitis B and C co-infected patients undergoing treatment for hepatitis C with direct-acting antiviral therapies. This was later published in the Annals the following spring. To understand why this can happen, we have to appreciate this phenomenon of viral interplay between the two viruses. Hepatitis C can exert an inhibitory effect on Hep B, as evidenced by studies finding lower hepatitis B viral levels in co-infection when compared with hepatitis B mono-infected individuals. So when you take hepatitis C out of the equation, there is an alteration in this immune synergy, and hepatitis B has the potential to come back in a fulminant way. But it does appear that hepatitis B reactivation with DAA therapy is much rarer in patients with isolated core antibody than those who have chronic infection. The estimated incidence of HBV reactivation is about 14% among those with chronic infection, and there are only 3 cases of occult Hep B reactivating with DAAs currently in the literature, which agreed is not necessarily an exact incidence, but it's thought to be quite rare. The bottom line is there's insufficient data to provide clear recommendations. The AASLD-IDSA hepatitis C guidance does, however, say that the possibility of HBV reactivation should certainly be considered in the event of any unexplained increase in liver enzymes during or after completion of DAA therapy. These guidelines do not necessarily recommend checking baseline HBV DNA levels to screen for occult Hep B in these isolated core antibody patients who will undergo DAA therapy. This is left at the discretion of the clinician. The other high-stakes situation is where HBV reactivation can occur when you give B-cell depleting immunosuppressive therapy. Rituximab, as many of you know, is a favored component of lymphoma treatment, and it is an anti-CD20 monoclonal antibody. It turns out that when you disable B-cell lymphocyte activity in the way that you do with rituximab, you can open the door to severe HBV reactivation. This can also occur with other forms of chemotherapy such as anthracyclines or other forms of immunosuppression such as TNF-alpha inhibition. The key thing to be aware of is that this phenomenon has been reported to occur not just in patients who are known to have chronic hepatitis B who are at highest risk, but even in patients with isolated core antibody. The presence of HBV DNA, which would indicate occult HBV, can be a predictor for reactivation in such settings. How to manage the potential of HBV reactivation is beyond the scope of this talk, but it is important to be aware of when you need to pay extra attention to this isolated core antibody status. So the question often comes up, should we be immunizing these individuals with isolated core antibody? There is no evidence to support routinely boosting these individuals. Remember, most of them have already been exposed to the virus, so immunizing against primary infection seems counterproductive. And remember that the majority of them have waned surface antibody. Having these low levels of surface antibody does not necessarily mean you won't mount a protective immune response when called upon to do so. The one exception here might be persons with HIV who appear to have suboptimal anamnestic antibody response to HBV exposure. Ultimately, immunization should be reserved for those with isolated core antibody whom you suspect may have a false positive. These are individuals who in reality have no HBV exposure at baseline, or in those who have HIV. This is the person without Hep B risk factors. They've never used drugs, are not on dialysis, or living in a correctional facility. Maybe they've only had one lifetime sex partner, etc. They are not from geographic regions such as Asia, Africa, or Pacific Islands, or other parts of the world even that have intermediate prevalence in the range of 2 to 8% for hepatitis B. This may include parts of Eastern Europe or South America. So you might ask, why should I immunize someone with no Hep B risk factors? Well, the CDC has issued a recommendation in 2022 to immunize all adults aged 19 to 59, regardless of risk factors. So this person whom you suspect has a false positive core antibody, if they fall into this age bracket, should ideally receive a full HBV vaccine series. So in summary, the core antibody is the most sensitive marker of prior exposure to the virus. It does not necessarily indicate active infection or immunity, but most of these individuals are likely to be immune with waned surface antibody levels. We have to consider occult hepatitis B and the possibility of HBV reactivation with hepatitis C treatment with DAAs or with B-cell depleting immunologic therapy. This is particularly the case if the individual is from an HBV endemic region. And then finally, immunize if they meet criteria for false positive core antibody or if they have HIV. To learn more about hepatitis B, please check out our Hepatitis B online curriculum, which contains a variety of lessons, cases, and slides to reinforce your knowledge. Thanks for joining me today.
The production of this Hepatitis B online mini-lecture was supported by funding from the Centers for Disease Control and Prevention.